presentation. Again, please hold your questions for Dr. Yu to the very end until we've had our final speaker. I'd like to introduce Dr. Bhatia. He received his medical degree at the All India Institute of Medical Sciences in New Delhi, India, and he completed his internal medicine internship and residency at the University of Connecticut Health Center. He completed his postdoctoral fellowship at Fred Hutch in Seattle, Washington, and his interests are mostly focused on clinical trials that look at skin cancer, melanoma, and Merkel cell especially, as well as kidney cancer. He's involved in a number of phase 1 and 2 trials, and today he's going to be speaking on sequencing therapies in melanoma. Dr. Bhatia.
Sequencing therapies. My talk will be mostly focused on the latest updates in immunotherapy. I do have a bias towards immunotherapy. I think targeted agents have made big strides in melanoma, and they definitely have a role. But because of my bias, I'll be focusing mostly. So these are my disclosures. We have had some wonderful collaborations with our colleagues in pharma. Together we have done several studies with research funding to our institutions. I've participated in a few ad boards. But when it comes to sharing the messages of my talk, I just want to assure you that those are all my personal opinions, and there is no collusion whatsoever. So I want to start with the case. Also want to apologize that I was actually a slacker in submitting my slides, so I will not be able to take advantage of that wonderful swim lane plot which keeps changing dynamically, and we'll have to resort to the old method of raising our hands for the options. So the case is, it's the same case I presented last year, and I just want to see if opinions have changed over time in this case. So 75-year-old man presents with multiple symptoms, constitutional symptoms, and right-sided abdominal pain. And imaging studies show widely disseminated metastases, including more than 50% involvement of the liver. Brain MRI also showed multiple brain metastases. The largest was 1.5 centimeter in the right frontal lobe. He did not have any neurological symptoms. And biopsy of a liver tumor showed metastatic melanoma with the BRAF V600E mutation present. The laboratory studies showed mild transaminitis. ALK-phos was significantly elevated. Bilirubin was 1.5, and the ECOG performance score was 2. So what will you recommend next? I'll speak the options first. So whole brain radiation therapy, PD-1 blockade with any agent that you choose, ipilimumab plus nivolumab combination, BRAF inhibitor plus MEK inhibitor, hospice. So let's go for option A. Please raise your hands if you would pursue whole brain radiation therapy, since this person has brain metastases. Okay, no radiation oncologists in the room. PD-1 blockade, ipilimumab plus nivolumab, right? BRAF inhibitors plus MEK inhibitors. Hospice. All right. Well, so whosoever made a choice for BRAF plus MEK. There were no takers for immunotherapy, and people are optimistic in this room, which I like in this day and age for melanoma. So I would agree, I would pick the BRAF MEK as well. So this is a person with multiple symptoms and bulky disease in various areas, and immunotherapy can work really well and lead to durable responses, but sometimes it doesn't work right away. But I think most important work reliably. It has 50-60% chance of working in the best circumstances, but then there's a 30-40% chance that it may not work. And in this person who's symptomatic, there is an option that BRAF/MEK inhibitors, they work much more reliably than immunotherapy. They don't work for long periods of time. They don't lead to durable responses. Generally speaking, some patients have durable responses. So if our goal is providing prompt relief in this person with possible impending liver failure and possible neurologic deterioration, I would definitely pick BRAF/MEK, try to stabilize his disease, and once we are in a more stable state, maybe then transition to immunotherapy. So I think you guys are all rock stars here right now in that choice. So I just want to remind everybody as to what the state of therapy for metastatic melanoma was. Until 2011, there were only 2 drugs approved. Dacarbazine was approved in 1975, and high-dose interleukin-2 was approved in 1998. And both those options did not have any proven overall survival benefit. And if we look at now, these are the list of agents that have been approved for since 2011. So on the left-hand side, you can see the immunotherapies. Ipilimumab was the first one, and then we have 2 PD-1 inhibitors approved very close to each other. The combination of ipilimumab plus nivolumab was approved a year later, and recently DVEC, intratumoral injections of DVEC. On the chemotherapy side, we have had BRAF inhibitors, vemurafenib, dabrafenib, and MEK inhibitors, trametinib, cobimetinib, and then the combination of BRAF plus MEK was proven superior to BRAF inhibitors. And most recently, we have had yet another combination with encorafenib and binimetinib that was just approved a few weeks back. So from now on, I'm going to mostly talk about immunotherapy. So we have anti-PD-1 agents approved as monotherapy or in combination with ipilimumab, and they are, I think, to be regarded as the current standard of care for immunotherapy of metastatic melanoma. We have 2 agents, pembrolizumab and nivolumab, and both those agents have been proven to be superior as compared to ipilimumab. So this was a phase 3 trial which randomized to ipilimumab and pembrolizumab, and as you can see, the response rates were much better with pembrolizumab, and it was also less toxic. So a win-win on both fronts. Similar results were seen with nivolumab. Again, response rates higher, toxicity was lower. So in this day and age, nobody should be picking ipilimumab as the immunotherapy of choice based on this data. And this is also translated into overall survival improvements. We also know that when immunotherapy works, it can work really well. With more mature data from ipilimumab shows that 20% or so of the patients who are treated, they become long-term responders, and they are alive at several years, 5 to 10 years later. And they may not be completely free of disease, but then obviously their immune system is reset in a way that provides the potential for long-term survival. Similar results have been seen with PD-1. The proportion of long-term responders may be even higher than what was seen with ipilimumab. And in this earlier study, which was presented 2 years back, close to 1/3 of the patients were alive at 5 years. And I think the real impact of immunotherapy still needs to be seen. We will obviously be watching for long-term follow-up data on patients who have been treated with combination therapies. So that was kind of the quick summary of where the field stands right now. But there are several questions that remain to be answered. And I'm going to just try to share my thoughts on these questions today. So the first question is, what is the role of combination therapy with ipi plus nivo? Second, is it safe to stop therapy in a patient who's responding to immunotherapy? And also, obviously, the $64,000 question is what to do in patients who do not respond to PD-1 agents. And last but not the least, how do we treat patients who have high risk of recurrence with systemic adjuvant therapy? So first question, what is the role of combination therapy with Ipi plus Nivo? So as you know, the combination was approved in September of 2015, and the approved dosing is worth paying attention to. So ipilimumab in this combination is given at 3 milligram per kilogram dose, and nivolumab at 1 milligram per kilogram, and the combination is given for a total of 4 doses every 3 weeks, the so-called induction phase, and then is followed by nivolumab monotherapy given every 2 weeks, the so-called maintenance phase. And this regimen was tested head-to-head in a randomized trial, which had 3 arms. One arm was ipilimumab, the other one was nivolumab, and the third arm was the combination. And as you can see here, nivolumab again was obviously better than Ipi, but Ipi plus Nivo had a higher response rate as compared to nivolumab alone, and that came at a cost of increased toxicity. So the rate of grade 3 or higher immune-related adverse events was substantially higher with the combination. So what does that tell us? Obviously, when we are mixing two immunotherapies, we are getting more immune stimulation in the body that is actually showing as being more effective against the cancer by virtue of higher objective response rates. But obviously, that's coming at the cost of greater toxicity. So the real question is,